So the CPOS trial was a phase 3 adjuvant trial in patients at high risk of recurrence, cutaneous SCC, after surgery and radiotherapy, randomizing between Cemiplimab and placebo. The background to this is that although cutaneous squamous cell cancers are very common, and the majority are cured by surgery, there remains a subset of patients who remain at high risk despite surgery and radiotherapy. And previously there were no effective adjuvant systemic therapies. We know that the anti-PD-1 targeting drug Cemiplimab is standard of care in patients with more advanced or metastatic cutaneous SCC, where it achieves a response rate of 47% and with responses that can be durable. So we really wanted to test if using it as an adjuvant treatment in earlier stage of disease with patients at high risk of recurrence could improve the outcomes and prevent recurrence in these patients. The CPOS phase 3 trial was a randomized phase 3 trial in patients at high risk of recurrence for cutaneous SCC. And patients were randomized in a double-blind, placebo-controlled fashion after surgery and radiotherapy to either Cemiplimab or placebo. Patients were selected based on high-risk criteria, based either nodal or non-nodal criteria that put them at risk of recurrence in the order of 45% risk. There were 415 patients randomized. They were well balanced between the two arms. Patients, as you'd expect for this disease, were elderly, median age was 71. They were predominantly male, white, and had head and neck primaries, which is what we'd expect for this disease. And about 60% of patients had what we called high-risk nodal criteria, which means that they had large nodes of extracapsular extension or a large number of lymph nodes. The key finding from the study in the primary endpoint was disease-free survival. We showed that Cemiplimab compared to placebo improved disease-free survival with a hazard ratio of 0.32, so 68% reduction, p-value less than 0.0001. In the placebo arm, there was a marked fall-off in disease-free survival in the first 12 months, consistent with what we know about these high-risk patients. The median disease-free survival was not reached in the Cemiplimab arm, and it was 49 months in the placebo arm. At 2 years, the disease-free survival in the Cemiplimab arm was 87%, whilst in placebo it was only 64%. We saw benefit in all pre-specified subgroups, including patients that had nodal high-risk criteria, non-nodal high-risk criteria, and irrespective of PD-L1 expression. This decrease in recurrences was due to both a decrease in local regional recurrences with an 80% reduction, and also a decrease in distant metastases with 65% reduction. Safety was good, it was well tolerated, and was as one would expect for an anti-PD-1 agent with no additional toxicities. And quality of life was maintained during the treatment with no significant differences between the arm. So this trial demonstrates that Cemiplimab is the first adjuvant treatment to demonstrate a statistically significant and clinically meaningful improvement in disease-free survival. It provides an option for these patients to prevent recurrence. As many of the recurrences are local regional, they can be associated with considerable morbidity. So it may be an advantage for many patients to have adjuvant Cemiplimab to prevent these recurrences from occurring.